Hi, everybody. It's 2 o'clock now, and we're just going to give everyone another minute to join and get situated before we start. We have over 150 people participating in today's town hall. And so, Raisa, do you want to give me a thumbs up when we have majority of the people on?
Maybe give it like a minute or two more.
Okay,
I'll give you a
sounds
thumbs
good.
up. Mhm.
Okay, I think we're gonna get going just for those of you that have joined, and we appreciate you joining us. And probably a few more people will be joining, but we want to be respectful of time. So welcome, everyone. We are excited to hold our second town hall since we started this journey. You'll hear from HMA and HCRS on the Enhanced Mobile Crisis Service. We have a full agenda today, and if we have enough time, we'll have a little Q&A at the end. But for now, I will turn it over to HMA.
Great, thanks, Sam. If we go to the next slide. Hey, so I'm John Volpe from Health Management Associates. We'll be covering part of this. I have the important task of doing some of the housekeeping. So first of all, just this notice, it's twofold. One, this meeting is being recorded, so just be aware that it's being recorded and that you should protect any confidentiality or proprietary information. Don't put that onto this town hall because this is going to be publicly available. And that gets to the second point, which is the records will be from this, including the printed materials, will be available upon request. And also, for those very interested, we will you will get an automatic email with the materials from this recording following the session. Next slide. So some housekeeping stuff. If you're comfortable, feel free to do so. If not, do not. That's fine. But enter your name and affiliation into the chat box and just press send. This will give us an idea of where people are attending from and types of affiliation. So it's just a good way for us to keep track of that. You're reminded that you're all muted and you cannot go off mute. However, there is a way to interact with us. And as Sam had said at the end of the presentation, we're going to, time permitting, go through some of the questions and answers. And the way that you're going to do that is through either Zoom chat or the QA feature, which is covered on the next slide. I'll show you. If you next, yeah. So you're muted, but if you navigate down to the bottom, to the navigation bar at the bottom of your screen, you'll see two options: QA option and a chat option. You can click one of those and submit your questions or your comments, and then we'll be tracking those during the course of this. And as I said, time permitting, we'll cover some of the questions if not all. So the next slide. So here's just a really high level. This is what we're going to do. We have some opening remarks. We're going to do a overview of the Community Mobile Crisis Program. HCRS team is going to talk about the Vermont statewide mobile crisis services, and as mentioned a couple of times, Q&A at the end. And we can go to the next slide, and I'm going to turn it over to Deputy Commissioner Crump for some opening comments.
Thank you, John. Hello, everyone. I'm Allison Crump. I'm the Deputy Commissioner for the Department of Mental Health. I really want to thank you all for being here and taking the time to learn about this new program. But before we get into the details of enhanced mobile response, I first wanted to start by acknowledging the existing mental health crisis services in the state. We have long had a dedicated network of crisis clinicians available 24/7 to Vermont communities through the designated agencies. And I know some of them are here today, and I'd like to start by thanking you for what you do every day, because there are phenomenal teams of people who are committed to meeting the needs of individuals in crisis. And I may be biased because I used to be one of them, as I served as a crisis clinician focused on children and youth at Northwestern Counseling for many years. And I still maintain that that job was the best and most important role I've ever had. Many of the crisis teams across the state also provide some mobile outreach currently, and others have provided mobile crisis in the past. The enhanced mobile crisis program you'll hear about today is in no way denying the incredible work done every day by the existing teams, but it rather serves to enhance our options for crisis response and also to ensure that enhanced mobile response service is available to be received by any Vermonter, regardless of their zip code. And that is something we do not currently have. So you'll hear it in detail today about what this term enhanced means for the service, but I wanted to highlight a few pieces that really signify an evolution in policy and in practice to best serve Vermonters. First, enhanced mobile crisis will support individuals experiencing a mental health or substance use crisis, which is a big step forward in our efforts to meet the co-occurring needs of the people we serve. Second, it will apply a multidisciplinary team. So a two-person team that will eventually include, with intention, those with lived experience who can support through their roles as a peer support specialist or recovery coach. And third, the threshold for dispatching mobile crisis is person defined, which is aimed at truly meeting the person where they're at. These are things we've talked about for a long time, and these are principles that were identified as high value for the community when DMH engaged in a lengthy process with regions across the state a few years ago in our Vision 2030 plan. So if you haven't seen DMH's Vision 2030 plan, we engaged in this effort prior to COVID. So for many of us, I know all of that is gone from our minds, but I'm putting it in the chat. And if you look at action areas 5, 6, and 7, you'll see specifically the community's wishes to meet people where they're at, to be person-driven and person-led, and to incorporate peer support specialists and person with lived experiences in the work. So those are 3 things that we're hopeful that this new program, enhanced program, will provide. Lastly, what excites me the most about this new program is it just makes sense. So I know when I used to get calls from a parent trying to manage their child's mental health crisis, telling them they had to get in the car and meet me somewhere, whether it was the office or the emergency department, did not feel great. And I want to acknowledge that we really haven't built this system this way because we want to. It's because it's how it's resourced, how it's been designed, and it comes from a certain model. And so this is our effort to look at that model differently and think about what needs to happen for it to exist differently. And so we can do things differently, but it will take funding, which we'll talk about today, and it will take partnerships. And I really want to take a moment to acknowledge the incredible partnership we found in the leadership and staff at HCRS, as well as their DA network partners. Without them, this would not be happening. So you'll hear from them today in terms of what's going to happen and what you can look forward to for how this program will roll out. And lastly, I want to acknowledge that none of this can work if we don't fully support existing staff and incorporate new roles and perspectives into the work. So that is something that we need to do across the board in this program and in others. So it's both exciting and overwhelming. So if you're feeling both of those things, you're not alone. But we're grateful for your feedback in this process, and we really appreciate you coming here today to learn about it and provide your input. So thank you, and I will turn it back to our partners at HMA who have been incredible guides for us in this work. Thanks so much.
Thank you, Deputy Commissioner Cronk. I'll take it away from here. Go to the next slide. Hi, everyone. It's wonderful to be with you. I'm a principal consultant at Health Management Associates out of the Boston office. I am a licensed mental health counselor and have been either providing as a clinician or managing as an administrator of mobile crisis services for well over 30 years. So pleased to be partnering with our neighboring state, Vermont, to implement these enhanced services. Allison touched on a few of these really key points. This is a funding opportunity across the country, not just Vermont. It's really an opportunity to improve the funding for states to enhance the existing wonderful network of crisis providers, but in recognition that to fund a two-person model, it takes additional funding. This started with the American Rescue Plan Act. Sometimes folks refer to that as ARPA. They've authorized a new Medicaid state plan option to provide community-based mobile crisis intervention services, which I'll define in a moment, starting April 1 of last year. So for the period of 5 years, the states have an opportunity to tap into increased funding for 3 of those 5 years. And Vermont has elected to start that in 2024. The states will receive additional funds under the Medicaid for these expenditures, provided they meet certain requirements laid out by CMS, which I'll touch upon in the next slide. But it's really most importantly an opportunity to see alignment across Substance Use and Mental Health Services Administration. You'll hear referred to as SAMHSA, National Guidelines for Behavioral Health Crisis Care, and CMS also issued guidance on best practices for mobile crisis services. National Guidelines for Behavioral Health Crisis Care, some folks refer to that as the toolkit. Really groundbreaking, came out in 2020, but first of its time to issue guidance across states around best practices for community-based mobile crisis services. That was really the guiding document for CMS's guidance on this new enhanced service. Really an opportunity also to establish best practices across all mobile crisis programs. I've said many times that you can look into Medicaid across all states, and some benefits are identical, such as outpatient therapy, and some benefits like crisis services really vary across the country. So a wonderful, exciting time in the space for crisis services to standardize best practices, increase funding to allow for a two-person response. And lastly, what really kicked this off was Vermont applied for and received a planning grant to plan out their intention to implement mobile crisis services. So an exciting opportunity for Vermont. A few years ago, they were one of 20 states that received that planning. Next slide, please. So these are some of the key requirements, not all, but the most notable requirements for CMS that states have to comply with in order to receive this enhanced funding. First and foremost, services must be available 24/7, 365. Secondly, the purpose. The goal of this is to provide rapid response, individual assessment, and crisis resolution by trained mental health and substance use treatment professionals and paraprofessionals in situations that involve individuals who are presumed or known to have a mental health condition and or substance use disorder. Vermont is one of many states that define a crisis as a mental health crisis. So this is going to be a change in practice for Vermont in many states. Again, the inclusion of substance use crises in the mobile crisis team response. Thirdly, services must be provided outside of a hospital or facility setting. Of course, there will be crisis services that respond to individuals in an emergency department. It's just that states will not receive enhanced funding for this two-person response to go into a hospital. So CMS is really sending the message loud and clear. They want this to be delivered in the community where the patients reside, and really an opportunity to move that volume outside of an emergency department. Another key component is team composition. This is really the most exciting. The requirement is that it be a multidisciplinary team, so at minimum 2 people, and that includes at least 1 mental health or substance use professional qualified to provide an assessment within their authorized scope of practice under state law, and could also include other professionals, paraprofessionals, and peers with expertise in behavioral health or mental health crisis intervention. So a wonderful opportunity for really recognizing the value of the peer workforce. Training, the requirements around training, just listing a few here: trauma-informed care, de-escalation strategies, harm reduction, and of course, substance use services. Next slide, please. So what informed this vision for Vermont? Well, nationally, obviously, we have 2 guiding documents, CMS guidance. In order to be eligible, you have to meet certain requirements as stated by CMS. And then, as I noted on the previous slide, SAMHSA's best practice for their community-based mobile crisis services. So they're really the genesis of this model in Vermont. There are many states that have already implemented best practices outlined in the best practice toolkit. So we really were able to look at what other states are doing and their successes and lessons learned. Vermont did issue a pretty broad-based survey. One finding from ED respondents in particular reported that 50 to 70% of individuals that present to the emergency department for a mental health or substance use related crisis could have been evaluated in the community. So that was pretty startling and not unlike many other states. The ED unfortunately tends to be the default for the location where individuals receive crisis services. That is not going to be the case in the future. We really want to shift that volume outside of the emergency department to where the individual resides. In the past definition, as I noted, was a mental health crisis, which excluded persons with primary substance use issues. So that will also be a pretty significant change going forward for Vermont. As I noted, the stakeholder engagement was pretty robust. There were webinars, key informant interviews, focus groups, and surveys, and findings from all of those were really integrated into the model that Vermont will describe in a moment. Next slide, please. CMS did note that it is required to monitor and measure outcomes. They did give some liberty to states to define what those quality measures were. Vermont elected to really select, these are pretty standard quality measures nationwide for crisis services. Of course, most people have a response time quality measure set for 60 minutes, which is an average, noting that sometimes it will be longer than 60 minutes, sometimes it will be shorter, but overall you want to achieve an average of a 60-minute response time. Another way to look at response is to look at, of all the interventions, about 85% of them did achieve that 60-minute response time. So it will be response time percent within 60 minutes. Another quality measure is location of intervention. Of course, this is community-based services, but we all recognize that services will be delivered in the mobile crisis team office. So really want to look going forward the percentage of evaluations that are occurring in the community and those that occur in the office. And you'll see for adults and youth, the quality target is a bit different. For adult, the target is 80% of interventions occur in the community and 20% occur in the office. For youth, that target's a little bit higher, 85% in the community base, and that's because schools provide a wonderful opportunity to see youth in crisis and stabilize them at that setting. So that's the 85% target for youth and 15% target for the mobile crisis team office. Another exciting part of this enhanced service is the ability to see individuals after the initial intervention. So follow-up services provided by the mobile crisis team, a wonderful opportunity to continue to hold and stabilize and support individuals in crisis until they get to the next necessary level of care if appropriate. So follow-up services by the mobile crisis team. The target will be that 75% of individuals receive some form of follow-up care. That can include a telephone call. It can include an in-person visit. And again, and this would be for individuals that are not referred to a 24-hour level of care. And lastly, disposition or outcome, really measuring the percentage of individuals that are referred to a diversionary service, which is basically anything other than inpatient level of care. So the goal is that 70% of individuals that are seen are referred to a diversionary service, and 30% might be referred to inpatient level of care. And these targets are based on national data and findings that are currently occurring. And for youth, the target's a bit higher, hoping to stabilize and keep 80% of youth in the community and referred to a diversionary service. And 20% we'll see referred to an inpatient unit for inpatient screening. So these are pretty standard quality measures. We see many states adopting these quality measures and similar targets. Next slide, please. So with that, I will pass it off to HCRS. Wonderful opportunity for you guys to meet them, and HMA has also thoroughly enjoyed our work with Vermont DMH and HCRS. So take it away, Ann and Kate.
Great. Thank you so much, Maura. And good afternoon, everyone. It is so nice to be here with you. And my colleague, Kate Lamphere, and I are going to facilitate this piece of the program. So I'll start off by saying Healthcare and Rehabilitation Services, HCRS, for those of us who might not know the acronym. We have been selected as the lead agency for this statewide effort for enhanced mobile crisis services. We are very excited to have been selected as the lead. We are in the process, we are going to subcontract with the 9 other designated agencies to provide a unified statewide, very robust community mobile crisis service throughout Vermont. I also just want to point out that the other DAs are our colleagues and have been working with us from day one on this, and we are so excited to all be moving forward on this statewide effort. On our staff side, aside from myself, Kate Lamphere is our Chief Clinical Services Officer, Mark Young is our Mobile Crisis Director, and Hal Moore is our Chief Financial Officer. And I also want to mention Dr. George Karabakakis, who is with us, and he is our CEO. So that is our lead team at HCRS. Next slide. Okay, so before we talk about the next steps, let's talk about our current mobile crisis services. You can see on this map that it shows by county the 10 designated agency locations in the county lines. And to the right of that are all of the designated agencies of the community mental health centers that hopefully many of us here are familiar with. And who provides the mobile crisis service right now? All of our DAs, these 10 DAs. So the crisis services are delivered through one designated agency in each region. And those services are available 24/7 in the particular DA's assigned region. And the services are currently delivered over the telephone, telehealth, community, hospitals, which include hospitals, communities, courts, and so many other locations. Next slide. And in terms of the program vision and principles, you've heard some of these concepts prior. This is a statewide equitable service model. We are looking to work from our existing strong community partnerships and also build those community partnerships. This is going to be a 24/7, 365 operation. This will be very community-based, where we are looking for this program to come to your home, office, or any other community-based location to provide those services. And as was mentioned by Maura, this is not intended to be on hospital grounds or in the hospital facilities. And we're hoping that this community-based model avoids unnecessary emergency department use and hospitalization, as well as law enforcement. We are looking at a program that is a rapid response model. You heard the 60-minute average time frame. This does address both mental health and or substance use related crises. It will serve all ages. No insurance or payment will be required, and there will be interpreter services available. Next slide. And for the next part of the program, I'm going to turn it over to Kate Lamphere.
Thanks so much, Ann. My name is Kate Lamphere. I'm the Chief Clinical Services Officer at HCRS, and I'm going to dig into the service delivery model. And I will start by saying this program is near and dear to my heart. Like the Deputy Commissioner, I started my career as a crisis clinician, and I know the impact that programs like this can have on people's lives. So the service delivery model, as Maura mentioned, is a 2-person response. where one of the people is a mental health and substance use specialist capable of doing an assessment, and a co-responder who might be another clinician or a peer support advocate or another crisis responder. The model is meant to be a rapid response to anyone in our state. Could be a visitor to our state or a Vermonter in the state, available 24/7, with screening and assessment being included, including an assessment of risk, primarily focusing on de-escalation and safety planning, really looking to assist people to get some relief from whatever distress they're going for. That's the primary intervention, is to support people to get some relief from whatever it is that they are experiencing. We are really excited about the integration of peer support services. There will be an interpreter service available, and one of the key elements will be care coordination and referral to other services within the community as needed. And that's across the spectrum of services. That could be a higher level of care, that could be other social services, it could be treatment providers, but really ensuring that we are able to help people get connected to whatever support they need beyond that crisis intervention. We're also thrilled that the response will be trauma informed, really looking at a safe and collaborative and culturally sensitive and compassionate response that really emphasizes voice and choice and empowers the individual who's in crisis to get the support that they need. And then additionally, providing follow-up services. So up to 3 days for adults and up to 7 days for children and adolescents, to really be sure that they are able to, that their needs were met, that they were able to get connected to resources, that they're able to use the safety plan to see if there needs to be any adjustment to what's been going on, or quite honestly, to just check in and say how you're doing, because sometimes it's just connecting with somebody in a caring way that can help somebody feel some relief. Next slide, Raisa, please. And, you know, I got this slide, key partnerships. I'd be hard pressed to think of somebody who isn't a key partner in this project. You know, first and foremost, the individuals who are in crisis and their families and supports, those are our key partnerships. The other designated agencies who are helping to build out this statewide crisis response are key partners in this project. We're also looking at fire departments, emergency services, ambulance providers who might otherwise be responding to emergency situations, advocacy groups and other agencies, faith-based institutions and other community partners, law enforcement, although you know, our crisis teams often co-respond with law enforcement, and we anticipate that that will still happen. We do hope that with the two-person response, it will be able to happen less. And it is important to note that law enforcement will never be the second responder. If law enforcement are responding, they're responding with that two-person mobile crisis team. So there will always be the two providers. We also are looking at community health providers, schools, educational institutions, the VA, and of course, any other community partners across the state who would be key partners. Next slide, please. So how do you access mobile crisis services? Well, luckily we access it nearly in the same way its crisis services are accessed now. Folks can call into the designated agency 24/7 crisis response line listed here, or they can simply call 988, and 988 will help get them to a mobile crisis service, which is just like we're doing now to access crisis services. Next slide, please. So what's new? We've gone over quite a bit of this, but first, there will be an in-person response. So there will always be one clinician. The second person will either be a clinician or another crisis response staff. We will be working towards the second person being a staff person with relevant lived experience. So a peer support advocate or specialist, a recovery coach, somebody who can lend their lived experience to support the person in crisis to navigate the situation. There will be a mobile crisis response. So there will be in person, always at least one person in person, but there will also be some telehealth. So a second responder who might come in via telehealth in order to take advantage of the statewide network of staff. There will be a new mobile dispatch system, which Ann will touch on a little later. The response will be in the community, really essential to meet people where they're at. The goal is to see people in the place where they are most comfortable and most able to access the support, as opposed to directing people to a facility or a hospital. We recognize that some people might still go to the ER, and that's fine. And we hope that people will find some comfort in mobile crisis being able to meet them where they're at. And we will be able to draw on statewide resources. So the network of designated agencies partnering together to create a statewide mobile crisis response. As has been shared earlier, this will include substance use crises in addition to mental health. You know, our crisis teams have long supported people with co-occurring issues going on. And we are thrilled to be able to expand beyond and support people through substance use emergencies. And we have some training that we are providing to our staff to be equipped to respond to substance use emergencies. Help Comes to You, really designed to help reduce stressors or get relief from distress. And the same crisis model that we've always had will still be available. So a crisis screener would go to the emergency room if somebody was in crisis in the emergency room. And this is really meant to enhance that service with the multidisciplinary team responding to the community. We think it'll have a big impact. We really do. We expect that we are supporting people to de-escalate from with a quick response to get people with trained staff. We want to provide support where and when it's needed, and the ability to serve more people. And also having a two-person response really does expand our ability to support family members or others who are involved in the crisis. Next slide, please. And last but not least from me, we expect that this is an alternative to the emergency department. So again, people might still go to the emergency department, and that's fine. But this is an alternative to long waits in the emergency department or entering into a medical system to get relief from distress. So meeting people where they're at, a timely response to support, directly connecting to people who are trained to be able to help them, and immediate access to that mental health professional in a crisis situation. Thank you very much.
Great. Thank you, Kate. So I just want to talk for a moment about the connection to 988, the 988 line. So the first thing that I want to point out is many of you may be aware that the two primary 988 agencies are DAs, NCSS and Northeast Kingdom. And we have been working very closely with them over the last 3 or 4 months to identify all of the connect points and the critical relationship between 988 and the enhanced mobile crisis. They are, in many cases, as we all know, 988 and the folks at 988 may be able to resolve crisis situations on the phone. They are also experts at dispatching services, and they're very, very adept at it and able in connecting people to the closest available help. It's an easy to remember number. And they have great experience working directly with the DA system, which is obviously very much what we want. Next slide. So I want to switch to program promotion, and I'll start off by asking you to take a look in the top left-hand corner, which is our new logo for Mobile Crisis of Vermont. You will see that on all of our promotions across the state. Our marketing and communications plan is both a local and a statewide marketing and communication plans. So I'll just share just a little bit of information with all of you, and we expect many of these items to be live in the new year. So we have created, or we're in the process of creating, a new website with a domain name of gethelpvt.org. So that will be front and center on everything that we do from an advertising standpoint. We will have many advertising venues. We will have TV, we'll have radio, we'll have online, such as the Front Porch Forum. We will have flyers, we will have business cards that identify it, and all of that information will be dispersed throughout the community and primary care, pediatrician offices, all of our community partners, So we will be planning on that big push to get the information out in the first quarter, starting in January. So, and we do have, by the way, flyers. The flyers are very specific to each region with local contact information. So our promotional program has very much a community feel with each designated agency, as well as a statewide look and feel to it as well, with very specific information. Next slide. So this slide is the one-page flyer that you will see out and about and on the public websites. And you can see that it captures the intent of this program, helping people feel as though they're never alone. We're available 24/7. These are enhanced mobile crisis services. Will come to you. So you can see across this whole marketing piece, and hopefully you'll experience how it feels to read this. And we're hoping that this will help draw people to the website, to the DAs, to call 988, whatever people need to do to get some help. Next slide. So we are looking at next steps. We are right now in a soft launch period where we are piloting and testing and out there doing two-person enhanced mobile crisis response when we can. We do have an official statewide launch for January 1st of 2024, so we're very excited about that. Next slide. And as Rice is moving to the next slide, I just want to introduce this. This is a video that we created for Mobile Crisis. I want to thank Rutland Mental Health for Mental Health Services for allowing us to video, and we hope you enjoy this video. So, Risa, you can play it. So, Risa, we can't hear that.
You cannot hear it.
No. It seems like it's very, very, very low.
I don't think it's playing through the Zoom. It may just be playing on your computer, right?
So let me try to play it from here. Risa, hang on 1 second. Oh, I'm not sure. Can I share? Should be able to share.
You should be able to.
Okay, hang on 1 second. Is everybody seeing that screen? Kate Lamphere, do you see a black screen?
Yes.
I do.
So we started doing a two-person response in the community, Mobile Crisis, this summer for a few reasons. Obviously, it is sort of the way that we're moving as a state. And I think ultimately, most importantly, is its best practice. So as soon as we could start putting that into place, we did.
It's reassuring and you can work collaboratively together and make good decisions together. We have each other's back, or we might say, I don't agree with that. Let's try this. Or how about this approach?
Going out with a case manager is helpful as well because, you know, they already typically have positive rapport. So it kind of sometimes will even let them lead a little bit and then, you know, ask the additional crisis questions that maybe they aren't thinking of, but kind of, you know, maintaining that rapport with them, especially if we don't have it or if they have had negative experiences in the past, you know, based on just, you know, anything. So I think that's been helpful.
I feel like that's always really valuable, especially if the person that we're responding to has a rapport built already with the person we're responding with. So that's very often the case with case managers, service coordinators. They're a trusted person in that
in that individual's life.
One of the things that I like best about the community responses, someone wasn't as comfortable with the other person that I was on the scene with. And so that person was able to take a step back, and then I jumped in and we were able to like build some more rapport. So I think it can be really helpful to kind of feel out the situation and what works best for that person.
My staff has been very happy with it. They feel like they are more able to be present with a client and get all the things done that they have to do in the community. They feel safer. We aren't really funded so much to de-escalate problems before they reach a certain level. This allows us to go out and assess a situation, de-escalate a situation, even if it doesn't evolve into an assessment for a higher level of care. And a lot of times that's what we're doing. In my mind, in an ideal world, we'd be doing very few assessments for higher level of care. We would be doing a lot of de-escalation and helping people get to the services that they need in the community.
I foresee a lot of positive impacts for ourselves and the community partners. I think that as crisis clinicians, we're gaining a lot more education and understanding from responding to community partners, to just visibly seeing the buildings that our clients go to seeing where they go day to day, meeting the community partners that we talk to maybe over Zoom or over the phone, and actually interacting with them. That's been really valuable. And then there's the added element of, while we're there providing that education, they get to see how we interact with the clients if the clients choose to have that happen. And I think there's an element of understanding that comes along with that, where they say, oh, I see what you mean when you say you can't just send them to the hospital, that, you know, the laws are in place to protect patient rights, and this is what that means.
It's nice to be able to go to them in a lot of ways, meet them where they're at, get more feel of what their environment is like, what they're going through. And then it gives you a better idea of what resources to provide to them, what level of care they need, intervention, things like that, of that nature. And then going with two people is a lot better. You have a backup person, and then you can also collaborate with that person. What should we do? How should we respond?
There was a 2-person response that my co-clinician and I did to a household where somebody had passed away. And really what the family needed at that moment was to have people there if they needed us, but really they were expressing themselves in a very appropriate way that a lot of people can feel uncomfortable with. So our role in that scenario was really providing education to everyone who responded to that really difficult situation. And then we were support for each other in processing that later that day, which I found was really helpful, because I was able to say to my co-clinician, we were able to say to each other, no, I think that was actually the most appropriate response. And would I have been able to say that if I wasn't there with her? I don't know. We can try to validate each other, but it's a different experience actually being there in it.
I have employees that are all saying this feels good. It feels like it's helping our clients more. It feels like we're more connected with our community partners. Feels good to have, you know, the director of the library call us and say, I just want to let you know, this was so helpful. Like, that feels good. We don't get that a lot in crisis.
So I just want to say a special thank you to Lori Zeif and all of our colleagues at Rutland Mental Health Services. Thank you so much for helping us with that video. And we hope you enjoyed that and that it gave you a sense as to what will change going forward. So Maura, I will switch it back to you for Q&A.
Absolutely. So I'm going to try to multitask here. Hi, everyone. I've been keeping track of the questions submitted in chat. But first, this is an opportunity for all of you, of course, to ask questions. If you could please submit them in chat, and I will do my best to monitor as we go through, and we'll get to as many as we can. So please go right ahead and enter your questions in chat. But let me just acknowledge, I did respond to Dan, but I realized the whole group couldn't see his original question, so let me repeat that. His question was, can mental health and substance use specialists, peer support specialists, be the 2-person team? If so, why not? And I did respond to the group that per CMS guidelines, this is a quote from CMS, the team must include a mental health or substance use professional, quote, that's qualified to provide an assessment within their scope, authorized scope of practice under state law. So since at this time in Vermont, peer support specialists do not conduct crisis assessments, the team cannot include only 2 peers. There must be a mental health or substance use clinician that is able to conduct that assessment. And now let me just go through the questions. There were a few questions submitted through the registration process, and I think a few of them have already been answered, but let me go through them. How will this be executed throughout the state? I think that was just one question. I think we answered that through HCRS's presentation, that this is a statewide model. HCRS as a lead entity subcontracting with their partners, the 9 DAs throughout the state. So there is a statewide network of community-based mobile crisis services. The next question is, what is the goal response time to someone or a family in crisis? We did review that with the quality measures. That will be an average of 60 minutes. And then there was another comment, will there be teams throughout the state for timely response? Yes, it's a statewide program. And then I'll pass this off to HCRS. Do we think we will have the capacity for and staff for this in the near future? So let me pass that one off to Ann or Kate.
Sure, I'll take that one, Maura. Thank you so much. Well, the designated agencies, along with healthcare in general, and certainly many other types of industries, continue to struggle with workforce challenges. So we certainly want to be upfront and respond to this in a way that is very real. We have differing staffing shortages in different DAs. It is not going to, it's not a challenge that's going to be solved overnight. We are moving forward with this program. We're going to do the best that we can. We do have a great staff right now providing crisis services, as we talked about earlier, and we have added quite a few positions for the enhanced mobile crisis. So yes, workforce is a challenge. It has been a challenge for many, many years, and it's not something we can solve quickly, but we are certainly working on it, and we have added positions. So we hope that will be adequate.
Thanks, Ann. Another one that was written into the registration process was, how will this enhance the programs already providing mobile crisis response? And again, that was responded to as well. The difference is the 2-person response and 24/7, as well as a requirement to be out in the community. And then another question submitted in registration, I'll hand this off to HCRS also. How will staff and client safety be maintained?
Yeah, I will take that one. And certainly safety is paramount when you're thinking of mobile crisis response. We do have established practices that promote safety for staff and clients that will remain in place. So those are the practices that we have with our crisis teams. We also are really excited that there is a consistent standardized training that everyone will, all of the enhanced mobile crisis staff will have be trained in, so that they are all equipped to ensure staff and client safety.
Thanks, Kate. And the final question submitted through the registration process is, how will persons actively using substances be supported? We have no resources for medical or social detox or residential treatment. And I'll pass that up to HCRS also.
Yeah, happy to respond to that. You know, as I said earlier, our crisis teams are well equipped to support people who have a co-occurring mental health and substance use disorder. This program was not meant to kind of address anything beyond the crisis. And I know crisis screeners and staff are really gifted and equipped at supporting people to navigate the complexities of our systems. And I'm confident that they will be able to do so.
That's good. Okay, now I'm copying and paste from the chat to a Word document so I can keep track of them all. I understand that you will continue to respond to the ED as usual. Do you, or how much do you think this will delay a crisis screener responding to the ED?
Kate, I think that would be a great question for you.
Yeah, I think we know that we're staffing this program to high utilization time so that we're able to meet the demands of our communities, including the emergency department and the community. So we don't anticipate having a delay in response to the emergency departments. But as we know, there are times where crises are all happening at the same time, like is happening right now. And so certainly there could be times where teams are out in the community and there is a delay, but we are staffing it adequately to be able to meet the demands of the community.
Another question in the chat. What about creating more mental health crisis emergency departments such as WCMHS has recently opened and co-located at their semi-peer support respite bed drop-in center?
I can jump in on that one and say we are excited to say, yes, we are doing that. So that Washington County's is not the only one. There's 6 contracts that the state currently has active to be standing up, and some have already been stood up. You know, Addison County has a great one called Interlude. UCS has an existing PUC, and there are 2 more that are to be contracted, one in Chittenden County and one in Northeast Kingdom. So love your comment and we're with you.
Another question in the chat, how many teams are there expected to be and how will this be staffed? I think that was answered and maybe this person joined a little late. 10 teams across the state, the existing DA footprint, and it will be staffed with a 2-person response. One will be a clinician and another one will be a mental health or substance use crisis response staff. Another question, please discuss how you are integrating current mental health first response crisis training into EMCR, i.e. Team 2, statewide, and CIT trainings, for example, Washington County.
So we are excited that Team 2 is one of the required trainings. So everybody on this involved in this project will have Team 2 training. And we worked with Kristen Chandler from Team 2 to add a couple of elements to the training. And we're excited that everyone will be able to have access to that training.
Let's see, are there plans for information sharing between mobile crisis clinicians and emergency departments when needed or primary care teams? Thank you for sharing this work.
So Kate, you're on mute. We have this
Because
existing.
I was talking to myself, trying to think how to answer the question.
Sorry, Kate.
Go ahead, Ann.
No, I was just going to say, we have this in place right now with our existing mobile crisis. So Kate, correct me if I'm wrong, but these are communication links that are already well established in our communities. Is that correct?
Yep.
Thank you. Okay, another question. So is it the vision that responders from 2 different DAs might respond to the same crisis, one via telehealth and one in person?
Kate, would you like me to start off? Okay, so the best practice model from SAMHSA is a 2-person in-person mobile crisis response, ideally delivered by the designated agency where the crisis is happening. That designated agency may already have that person as a client, but also certainly is the best to respond in so many ways in terms of proximity to location, understanding of resources, it's in follow-up, et cetera, et cetera. If a 2-person in-person response is not available at that moment, then that designated agency will internally try to identify if there's a 1-person in-person and a telehealth from that same designated agency to be deployed to a crisis situation. In the event that a particular designated agency doesn't have the capability to do either of those scenarios or some piece of it, there is now going to be statewide resources available, which is a wonderful part of this program, where if a designated agency can send 1 person in person, but needs a telehealth, but they don't have somebody from their own designated agency, we will have a mobile dispatch model and telehealth and clinicians across the state and paraprofessionals and other crisis staff available for telehealth to be a present for that 2-person. There also may be times when we cross county lines. So, you know, the county lines are really great. They're wonderful, but this is a statewide program. So if a particular designated agency cannot respond within their county, their catchment area, but another designated agency can respond with a 2-person enhanced mobile crisis response within a reasonable period of time. We will deploy whichever team can get there the faster from whatever DA, with the DA of a catchment area being the primary DA that is always consulted first. So this is great. It brings many more resources, both through telehealth and the ability to cross county lines, so to speak. Sounds silly, but it's not. It's a statewide response, and that's how we'll be handling the mobile dispatch on this program. Great question.
Please discuss how you are integrating all community first responders into EMCR, for example, law enforcement, EMT, domestic violence service providers, etc.
I'm happy to start. I mean, I think this is the first step where we're sharing all of the information. I think we have communications that will be going out to be sure that everyone knows about this program. And then each designated agency is really well integrated into their communities and will draw upon their key partnerships as they see fit. We're really lucky that we have partners across the state that are really well established in their communities and will connect with people as needed.
Okay, how will 911 dispatch be trained, and how will there be a system in place to forward crisis calls to mobile dispatch?
Another great question. We are working it diligently. We have been for the last 3 or 4 months. So first of all, we are Sam and a number of others are working with us on a new software platform that is a mobile dispatch software platform, that will really assist us greatly in the statewide dispatch modeling. So we're very, very excited about that. In terms of the technical aspects of how will calls move from 988 to a designated agency for a response, or if the designated agency gets a call but they can't respond to it completely, what happens then? They would go to a mobile dispatch. All of those technical details are still being worked out, but we are going to be following all of the best practice mobile dispatch protocols that are in place across the country and many other mobile dispatch models. So we are still working out the final details, but we expect it to be again benchmarked against best practice with dispatch.
Okay, thanks. Another question. What policies, procedures, structural changes, training, etc. are being planned for that will help shift the focus and set providers up for success in shifting from a triage gatekeeping model to a relief from distress model? In what ways, besides quote intentions, is it designed to help reduce stressors? That was a long one. I can try to put it back in the chat for everyone to see.
Kate, do you want to start on that?
Yeah, I mean, I think that there's a lot to that answer, and I will. There's a lot that is involved in answering that question, and I think I will start by saying we have created a very robust series of trainings that will assist with that transformation. And I think, working with the emergency services directors and the designated agencies, everybody is really interested in moving into that space and getting their staff trained. And I think I'll leave it at that because there's a lot more details and nuance into it, but there's a lot of attention being paid to it.
Thanks. Right. Got both chats going on. Okay. Okay, that's great to hear that it's great to hear that can other DA teams be remobilized? I may have missed this, but does that mean there will now be one central intake number statewide for crisis?
I'll take that. So no, there will not at this point be one number. Anyone in crisis can call 988 and anyone in crisis can call DAs directly. So at this point, that is the model.
How do your aspirations for disposition and outcome goals for this enhanced mobile crisis compare to current stats for crisis screenings? So in other words, I think also, does that mean maybe that data is not currently collected for these current outcomes, for the outcomes for the enhanced model? Is that correct, folks, from Vermont?
Kate?
Let me repeat the question. How do your aspirations for disposition and outcome goals that we show the outcome goals and the targets? How does that compare to the current statistics for crisis screening? So I think it's a great question, but my understanding from knowing the data in Vermont that those are not the current crisis targets. So data is not collected. So these will be new quality outcome goals, and this will be new data to look at statewide and also by service area. Did I get that right, Sam? I see you nodding.
Yeah, you got that right.
Okay, thanks. And great question. Is enhanced mobile crisis voluntary? And I see we're at time, but absolutely, all services are voluntary, enhanced in person, but it's always defined by the individual and optional and voluntary. And we are at time, and 3 more questions popped up, but I do realize we have to close, but I think we got through a lot. We had more than a 15-minute Q&A, so I do want to thank you all, and any parting comments by Deputy Commissioner Cron for ACRS.
I'm just impressed by the questions, and please continue to reach out to us. We're happy to answer ones that did not get done. Thank you all.
Thanks, everyone.